Hi everybody, welcome to our International Research Event 2021. It's World Kidney Day and I'm absolutely thrilled that we've been able to invite the speakers we have from not just the UK but Sri Lanka, South Africa and Australia. And I think you agree with me, we've got a fantastic programme, and I thank you, Miriam, for pulling this all together for us. And I hope the talk's going to be interesting to everybody. So I'll just give you a little bit background about myself. So I'm Wendy Cook, and I have a son who's got FSGS, who was diagnosed when he was 5 years of age, about 2.5 years. After that, he sadly had to go on dialysis, and about 14 months later, he was given the gift of a kidney, but tragically, he had reoccurrence in the kidney, and it was about that time when I met Professor Moin Saleem, and he told me about the charity that had been set up. But there was nobody available to actually build this charity up. And so I agreed to take on that task. And that's what I've been doing for the past 15 years, slowly building up the charity. I've got a lovely, I've got some very lovely volunteers who fundraise and support the research team at Bristol. And also, obviously, I answer many emails, not just from the UK, but from abroad as well, about different topics regarding nephrotic syndrome, and also our charity gives a lot gives a lot of information to people in regards to treatments and updates on the latest developments of research. And also hopefully we raise awareness in not just our local communities, but the whole worldwide community as well. But also I personally and others support other researchers here in the UK, not just at Bristol, but also in other countries as well. So we have several wonderful speakers here with us today, and we'll be taking questions at the end, and I'll ask you to put the questions in the comment box if you would. I need to let you know that the speakers can't answer clinical questions because obviously they don't know your child or your medical histories. So if I could kindly ask you to refrain to ask those sort of questions and only ask sort of questions relevant to the topics they're talking on, please. And I'll also ask if the speakers could introduce themselves, because that would make the programme run more smoothly. We haven't built a break into the programme because obviously we wanted to try and keep to the times as best as possible, because I know some of the speakers have got clinical duties to go back to, but what I would say is if you need to go and make a cup of tea, cup of coffee, please do. We won't be offended if we see you drop out on the call, or if you just want to switch off your camera and come back in a few minutes time, that's fine. This is all being recorded and it will be uploaded onto the YouTube channel in the next few days, and Miriam will circulate the YouTube channel, YouTube channel link, so you can let other patients and other colleagues know that this is actually something they can watch and share with others. So I think that's all I have to say. So I think if we could kindly go to our first speaker, Dr. Gavin Welsh. Thank you.
Hi Wendy, thanks very much. Let me see if I can share screen. Can everybody see my screen? Yeah, is that?
Yeah, yes, we can see your screen, Gavin.
Brilliant. Okay, so I'm Dr. Gavin Welsh. I'm Associate Professor of Renal Cell Biology here in Bristol. And I'm just going to give you a quick overview of some of the things we're doing within the lab team. No, it's not. Okay, so what we do is we work on the kidney, as you'd expect, which is the world's most sophisticated filter. And what we're really interested in is these structures called the glomeruli, which is where the blood's filtered into urine. And what we're especially interested in is this structure called the glomerular filtration barrier. Now, this filtration barrier is a very highly selective filtration barrier. It's made up of 3 layers, and the 3 layers are the endothelial cells. I hope you can see my pointer, the glomerular basal membrane, and these cells on the urinary side called the podocytes. And all 3 layers are thought to have an important role in the filtration process. And in fact, injury to any layer of this barrier leads to proteinuria, but how this happens is poorly understood. And in the lab in Bristol, we work on both sides of this layer. And so we're interested in both the podocytes and the endothelial cells. So here's a picture of the cells that I work on together with Moin Saleem, and these are the podocytes. And you can see that these are a beautiful cell type which have a main cell body and then all these interdigitating foot processes. And it's through the slits in these foot processes that you get filtration. So breakdown of this beautiful structure is one of the outcomes of nephrotic syndrome. So in nephrotic syndrome, this structure starts to break down and you get protein leaking into the urine. So simply with the kidney filtration system, here's your glomeruli, blood enters, it's filtered by the glomeruli, and waste products go to urine, and the clean blood exits the other side of the glomeruli. And we're interested in why this process breaks down and how this process breaks down. So here's an electron micrograph of the filtration barrier. And you can see that this filtration barrier filters 180 litres of blood a day, but no protein goes across. And actually protein in the urine is a cardinal sign of kidney disease. So what happens when this filter breaks down? Well, essential plasma proteins leak into the urine. So things like circulating antibodies, clotting factors, albumin leak into the urine. And what happens is you get a gradual loss of these glomeruli structures, chronic kidney disease, and ultimately end-stage renal failure. So you lose your kidney. So this is what happens in nephrotic syndrome. And we're really interested in how this process starts and can we block this process. And on the right is 2 famous people who've had nephrotic syndrome. The top is Jonah Lumu and the bottom is Andy Cole, Manchester United football player. So we're interested in understanding how this disease happens, what happens in this disease, and can we reverse it? So as I said, if you get breakdown of this barrier in nephrotic syndrome, you lose these essential circulating proteins. But the issue is in most cases, there's not an understanding of the mechanism behind this. And this disease is a huge disease burden, and there's lots of complex outcomes post-transplantation. So we really need to, A, understand this disease, and B, can we develop new tools to treat this disease? So here's the beautiful podocyte structure that I showed you earlier. And here's what happens in nephrotic syndrome. This beautiful structure is broken down. You lose these beautiful foot processes. You get what's called foot process effacement, and this leads to protein leaking into the urine. So one of the things we're looking at in Bristol is gene mutations that cause nephrotic syndrome. And one of the things, what a gene mutation is one change in your genetic code that gives out a different message. So DNA is the DNA sequence is what codes for the proteins in your body that tells your body what it needs to do. But one change or several changes in your DNA can give a totally different message. So if you look at this simple example, changing one letter in "my cat is black" changes the total meaning of this sentence. So that's what happens in some forms of nephrotic syndrome. There's genetic mutations which cause a change in the message in your cells. So your cells is producing a totally different protein, and that causes disease. Now we understand a lot about the genes, and new genes that are causing nephrotic syndrome are being found every day, it seems. And we're through the nurture cohort, which Moin will talk about later, are trying to understand these mutations through the patient cohorts we're developing across the UK. So a deeper understanding of these and deeper understanding of the mechanisms is needed to find new treatments. However, because some of these things are known, some of these mutations are already known, we've been starting to wonder whether we can use gene therapy approaches to treat nephrotic syndrome. Now, as I said, in patients, they have a defective version of the disease, of the gene. So we were wondering whether we could use gene therapy approaches to give cells to put back a healthy version of the disease, a healthy version of the gene to the cells to restore its function. Now, this technology is being used in a lot of diseases now, and a lot of new drugs are coming out. So we were wondering whether it works in the kidney. So Dr. Wendy, who's worked in our lab, has developed adeno-associated viruses that directly target the podocyte cells of the kidney, which is the site of the disease, to give them a functional copy of the mutated gene. So what we're doing is we're saying, can we restore a healthy gene specifically to the podocytes to give you a healthy copy of the gene, and can that treat disease? So what are AAVs? Well, they're small viruses. They can transduce terminally differentiated cells, which is really important because the podocyte in your kidney, in your glomerulus, is a terminally differentiated cell. And the first licensed drug for gene therapy has been allowed in Europe. More drugs are coming through. So we're working on developing these viruses to directly target the podocyte within the kidney to give them functional copies of mutated genes. So the idea is, here's your glomerular filtration barrier. We know the genes that are mutated in nephrotic syndrome. So can we use the virus to put healthy genes back into the podocyte to correct the disease and hopefully treat genetic forms of nephrotic syndrome? And lab work over the last 4 to 5 years has shown this is possible. So in animal models, we've been able to treat animal models of nephrotic syndrome with these viruses. And so now we're at a very exciting stage where we can hope we can take this forward and try and develop this into a clinical tool. This has led to the formation of a new company called PureSpring, which is designed to take these gene therapy tools from the lab and develop them into clinical tools that could be used in the clinic in the future. So this is very exciting, and we hope this meets with a lot of success. So what is the future of nephrotic syndrome? Well, we hope treatment opportunities for the common glomerular diseases are non-specific and they're barely altered in decades. We hope from our lab work that we can understand the basic biology of the glomerular cells, the podocytes and the glomerular endothelial cells, so they will hopefully alter our thinking of the disease, how the disease occurs and how we can treat it. So we're hoping these conceptual advances will lead to novel, targeted therapies within the span of the next generation of children that clinicians see with kidney disease. And we hope that we can start producing really good
applications. They all have
Thanks for listening.
Thank you, Gavin. Have we got Hugh with us?
Yes, indeedy.
Hi.
G'day.
Good day.
Okay, the new one.
Shall I, you happy
Yeah,
for
if
me
you'd
to
like to
start?
go ahead and introduce yourself, that'd be lovely.
Sure.
Thank you.
And can I just quickly ask, if you're not part of the guest speakers, could you
other one.
please mute your computer for us, please? Thank you.
Okay, can you see my slide?
Yes, that's super.
Can you tell
Thank
it's,
you.
can you tell
Yes,
it's mine?
lovely. Thank you very much.
All right.
Lovely.
Well, look, first up, thank you very much for the invitation to speak today on World Kidney Day. I hope it's possible for people with kidney disease to be living well. I was super pleased to be invited. Slightly sad we weren't doing an equivalent one in Australia, and it's really given us the impetus to get going with building a nephrotic patient advocacy group in Australia as well. So I'm a children's kidney doctor. My only disclosure today is that I used to be a Bristolian and got strong-armed into research by several of the speakers here today, although they seem to have taken off since I left, but I'm not going to take that personally. And I promise this is the only kangaroo you're going to see during this talk. So rather than a specific project, I'm going to tell you a little bit about what we're doing in Australia at the moment. First up, I thought I'd better tell you a little bit about Australia. It's a big place. If you stuck Australia onto the US today, it would take up about 70% of the landmass. But we only have 26 million people living here. Of those, about 7 million people were born overseas. And so it's really quite multicultural, more so than I expected when I first came out. But most of the people in Australia live within suburban hubs, and there's wide spaces of land with just desert. Just under 3% of our population identify as Indigenous, and across the country we have 8 paediatric nephrology units, which is not a lot, and they're very spaced out, as you can imagine. This is where I work at Children's Hospital Westmead, or at least it will be when it opens in a year or two. The current building's a little less pretty. So telling you a little bit about research that's going on in Australia at the moment, definitely our focus over the last few years has been in the genetics of kidney disease, and we've really come together nationally as a group of clinicians and researchers and molecular geneticists, clinical geneticists and pathologists, and we've managed to form a conglomerate that provides a renal genetic clinical service in every state and territory, and with easy access to genetic testing, and that's really come on leaps and bounds. And then because of that, we're able to then identify families who benefit from research testing if we can't find anything on our first lot of testing, and so we have pipelines for letting families go through a research genomics process. And with some help from podocytes from Bristol, we've recently been able to start looking at some of the genetic results when we get answers that aren't particularly clear, neither positive nor negative, and we're able to use podocytes to help clarify whether they're disease causing or not. And gene therapy, I might touch on a little bit later on. We've also done a bit of quality improvement work, again centered around the renal genetics service. So we were very pleased with ourselves when we introduced it around the country, not just for families with nephrotic syndrome, but all sorts of kidney diseases. But we realized we never really asked patients and families what they thought of the service. So we're going to go back and see if we're really providing the level of care that we thought we were, and if not, then we will change the service to adapt. We also are a little bit behind the UK in terms of what's available online for our patients and families, and again, I'll talk a little bit about that later, but we're going to start improving what's online for local families. We had this great idea, and we know it was a great idea because you guys had it about a year or two before us, that we should be developing an app for families living with nephrotic syndrome to enter details like urine dipstick results, alongside medication dosing and weight and that kind of thing, using paper diaries. Seems very old hat, 21st century. So that's in process, led by a colleague of mine in Perth, Nick Larkins. With help from Wendy, we're going to collect similar information, so that if we ever want to research how useful the app is, we can combine that output. A friend of mine, Dr. Anna Francis in Queensland, is looking at a little epidemiological study where we went back at all the children who had transplants over the last 20 years for FSGS, and looked to identify what affected their long-term outcome. And Wendy Ling, who Gavin spoke about earlier, with Moin and Gavin, wrote a paper about children who are initially steroid sensitive, become steroid resistant later on, seem to are less likely to have a genetic cause. And certainly we found that those children also seem to have more problems post-transplant. And transplants don't seem to last as long in them, and that's going to be really interesting to try and understand why. I think Martin Christian is speaking next, and we managed to persuade Martin that we'd be a good collaborative group for participating in clinical trials, so try and help speed up getting results out of trials. So the Peradeniya group has been extremely successful, as most of you probably know, and we would like to help. I think our paediatric nephrology setup is very similar to the UK, and feel that we could hopefully collaborate and productively. We also want to look at another international trial, looking at what we use after steroids if steroids don't work, and why one might be better for some patients than others. And lastly, going back to what was drummed into me several years ago, that the podocyte is king, looking at podocytes in the lab. And a few years ago, similar to what Wendy Deling is doing now, looking at getting into podocyte cells with vectors that allow you to change the genetics of the cell. We were starting to do that in the lab with the cell lines, but we've kind of moved away. We recognize that other groups are going to be doing it bigger and better than us. So currently what we're doing is looking at why our immune cells, or rather how our immune cells change when we use rituximab for children with frequently relapsing steroid sensitive nephrotic syndrome. We understand it's a very effective drug. We don't really understand why it works so well. So we're going to look at how it affects our immune cells and whether there are patterns that allow us to get a bit more information out. Now, I told you that we're very proud of ourselves. This collaborative group is called KidGen, and we, like I say, we've got renal genetic clinics in every state and territory, and that's useful up to a certain extent for families with nephrotic syndrome. And these are some of the other bits of work that we're doing within that group, mainly around gene discovery and modeling of genes, and understanding how we might be treating them. For those of you who know me of old, where my PhD in Bristol involved setting up radar as it was back then. Foolishly, I've decided to do the same thing over here. More blood, sweat and tears, but and this will be online pretty soon, and it will allow us to build build cohorts of patients and families living with nephrotic syndrome and a bunch of other kidney diseases, and that allows us to collect information to be able to study the disease in a bit more detail. And I'm sure Moin's going to talk to you about the evolution of that later on. Interestingly, Gavin, talking about the gene therapy, I mean, the work in Bristol is absolutely fantastic. In Sydney, we have next to our hospital, there's a medical research institute, which has really been a centre for gene therapy in Australia for children. Introduced a couple of drugs for neurological conditions such as spinal muscular atrophy, and it's been very successful. And we've been working very closely with them, and we've been able to identify a couple of kidney diseases where, interestingly, the protein is within the liver rather than in the kidney, protein that's affected, and we're looking at targeting those. but we're very much a centre that's keen on doing gene therapy, and so we're hoping to attract ourselves to any pharmaceutical companies doing clinical trials in gene therapy for kidney diseases from the US, Europe, and beyond. Okay, now for those of you who feel sorry for me because I'm going to be staying up late tonight, don't worry, this is what I'll be doing tomorrow after clinic. And look, I'm going to finish up there. Acknowledgements would go on forever, but these are some of the people working in the lab who've been looking at the podocyte cell and the gene therapy models. So thank you very much for your time, and happy to take questions now or later as appropriate.
Thank you, Hugh.
Stunned silence.
Yeah. Any questions for Hugh? Anybody? I can't see anything in the comment box, but if you've got something later, anybody, just pop it down. And are you staying on the call, Hugh, to the end?
Let's see how I go. I'm pretty old now. I don't know how late I'll be able to stay up.
What's the time in Australia at the moment?
It's 9:30, but I am pretty old.
Oh, right. Okay. Okay. Well, if not, if there is, then I can email you.
Pass them on to me. That's absolutely fine. Yeah.
Yeah. Okay. That's lovely. Thank you, Hugh. I'll be in touch about the app. Thank you. Thank you very much. Okay, if we can go to Martin Christian. Is he online, please?
Hi, Wendy. I'm here. Yeah.
Hi.
Okay. Let me try and have a success with screen sharing than I did at the APN meeting last week. Hopefully you can see my slides just now. So thank you very much for the invitation to speak today. I'm Martin Christian, a paediatric nephrologist in Nottingham in the UK. I wanted to give you a very whistle stop tour about how steroids are used in children. And the next 10 minutes really race through how we use steroids at the start of the nephrotic syndrome course, how we prevent relapses, think about the side effects of steroids, and think about treating relapses with steroids. I'm going to start with this, which will be familiar to some of you. This is called the forest plot and comes from the Cochrane collaboration, which is a group that look at evidence-based medicine by combining the results of research studies. Now, back in 2005, this was their conclusion about studies that looked at steroid dosing for the first episode of nephrotic syndrome. The little diamonds that are circled fall to the left of that vertical line, and so for the duration of the steroid course at the top and for the total dose of the steroid course at the bottom, because the diamonds are to the left of the line, that suggests that giving longer and giving higher doses of steroids are beneficial to children at the start of nephrotic syndrome, and that's what we believed at that time. But there was also a lot of concern expressed about the studies that we used to inform that conclusion, a lot of design issues, potential bias in the studies. So fast forward a little bit and into the last decade. First of all, you had a Dutch study in 2012 looking at the total duration but not dose, and then two studies published in the same edition of Kidney International in 2014, the Japanese study and this Indian study, and all of the studies together showed that in fact if studies are designed well, there was no difference as to whether you gave a standard 2-month course of steroids or whether you gave a prolonged and a higher dose, cumulative dose steroids. Peradeniya study, which was set up by Nick Webb, was set up before any of these three studies were published. The main study started in 2011, but a pilot study even before that, and 237 children were randomized across what was the largest multi-center study in the UK at that time. And like the other studies, it showed that there was no difference in the time to first relapse, depending on whether you gave a prolonged steroid course or a standard steroid course. And so we're back really to where the original international consensus started, that we are giving a shorter course. And this is the latest Cochrane forest plot here. So if you look at the bottom, I'm not quite sure if my cursor shows up on your screen or not, but the bottom plot here still shows the diamond to the left. But if you look at these 4 studies I've just briefly showed you, the diamond now falls right the way across that vertical line. You know, these are the studies that are at low risk of bias and that there is no difference. So I think that's a good thing for children, because we don't like steroids, and if we can get away with giving fewer steroids, smaller doses of steroids, we think that's a good thing. So what about moving on then to preventing relapses? We know that at least 80% of children with steroid-sensitive nephrotic syndrome will relapse. How do we use steroids to prevent relapses? Well, of course, what we use to start with, but in fact the evidence for giving them isn't very good. And then this study from 2019 was published of 61 children, but not so much trying to see whether giving steroids or not helped, more to see whether if we give steroids on a daily basis rather than an alternate day basis, does it matter? And so the dose of steroids that we give every other day is usually being around about 0.5 milligram per kilo body weight. But if in this study they gave half of that dose, so about 0.25 milligrams per kilo every day, and compared it with giving the standard 0.5 milligram per kilo every day, and to my surprise at least, they showed that the daily steroids, the ultra low daily steroids, were more effective than giving the alternate day steroids. So that's a very interesting finding, particularly if we want to think a little bit more on how we think steroids might be working to prevent relapses in nephrotic syndrome. And then the next question really that I've been involved with in taking over this PREDNOS-2 study from Nick Webb is to think about how steroids can help at the time of an upper respiratory tract infection, because we know that intercurrent infections tend to provoke relapses. And 3 study groups, Matthew's group in the Middle East, Asiri Abeyagunawardena's group in Sri Lanka, and Arvind Bagga's group, which is a Gulati paper in India, all looked at this question and all showed that if you give steroids at the time, low dose steroids at the time of an upper respiratory tract infection, it prevents a relapse. Nick felt that this was worthy of a larger multi-center study, and some of the concerns relate to the generalizability of the results, because those 3 studies all took place in countries that have got a very different infection profile to the UK. And as you can see from the table here, all of these studies were done in children who were taking background prednisolone already. Asiri's group then repeated the study, not with children not taking any steroids at all, and still showed the effect to be important. So PREDNOS-2, I'm sorry that I can't share results with you. The results are out, and the paper is just about to be submitted, but I'm not allowed to share those results at the moment. But do watch this space, because as you can see, it's a large study, and these results are going to be important in informing our future discussion. Just to pause for a moment to think about how we do use steroids in nephrotic syndrome. And I'm keen to try to help to clarify our thoughts about how we use steroids. If this is a pictorial representation of a child with steroid nephrotic syndrome along this time axis here, and this represents relapse, we treat relapses with daily high dose steroids to start with, and then we cut the dose down for a while to give about 2/3 of the dose, but every other day usually. We may wean those doses, sometimes we do, sometimes we don't. And some children then we maintain on low dose alternate day prednisolone, or as I've just shown with the Yadav paper, perhaps ultra low daily prednisolone. So if we call this initial dose the induction dose of steroids, because a little bit like giving chemotherapy for cancer, that's about trying to induce remission. But then we want to consolidate the remission, and that I think is what that next phase is doing, and that's all part of the treatment of the relapse. But to maintain the remission, that's a slightly different use of steroid. But all of these steroids contribute to steroid side effects. So the study that Hugh told you about that we are keen to push through is to think about whether we can get away with giving a lower dose of steroids to treat relapses than we currently do. And the background to this comes from studies from 30 years ago in uncontrolled ways, which showed that lower doses of steroids are helpful. More recently, a retrospective review from Great Ormond Street, the Raja in 2017, showed that it can be effective. But then we've had in the last couple of years a couple of small studies, this one from Israel and this one presented at the International Paediatric Nephrology Association 2 years ago, showing that lower doses of prednisolone do seem to work as well as standard prednisolone and don't seem to result in an earlier relapse. So thinking back to this, what I showed you about induction versus remission, two important large papers have been published in the last couple of years that look at the consolidation only phase of the relapse. The Propine study here from Italy and Arvind Baggar's group again, both not showing that there's any difference in whether you shorten or lengthen this consolidation period. But the overall question as to whether the cumulative dose of prednisolone is helpful has not yet been addressed. So the Cochrane updated review that I showed you before has published this conclusion, and this is what the text says here now, that we've established that the dose of prednisolone for the initial episode doesn't need to be lengthened or increased. And it now feels like the most important question about steroids in nephrotic syndrome is whether we need to go lower. So starting off with the relapses would be the right thing to do. And we feel that this is the next important study that we progress. So a quick word about steroid side effects. I think those of you that know nephrotic syndrome personally will be very familiar with these sorts of side effects. And we know that the parents of young children are most concerned about the behavioural side of effects on children. And we've all, and they've been written up as side effects generally in children who take steroids, and particularly in children with nephrotic syndrome. We've always struggled with trying to quantify steroid side effects. So one aspect that we'd like to bring into this new trial is something related this, which is an adult measure, but now adapted to children too, of trying to quantify steroid toxicity. You've heard from Hugh that we are planning to submit with Australians. We tried before we had these discussions with Hugh, we tried to submit this 2 years ago, UK funding, and weren't successful, unfortunately. So we've served out a moratorium, we have considered the study design, and we are now looking at submitting plans for early May for funding, and hope that we can get this. We now know it's not just us that think it's an important study, Cochrane thinks it's an important study too. And I hope that I might be able to come back in the future and perhaps tell you some results of this. So just to leave you with this last slide, which is a sort of a philosophical slide that sums up, I think, where we're at of a sort of a windy road of nephrotic syndrome at the moment. And on one side of this windy road, we're trying to steer a course with a condition which is a chronic disease, which has a lot of steroid use both at the outset and then later on, and people are starting to think about, what can we do to try and reduce the steroid burden? Should we be thinking about second-line treatment early on, even at the start? And yet, some of the information that I showed you here seems to say, well, actually, you don't need to give so much steroid for many of these children. Low doses of steroids might be as effective. Prolonged steroids at the start doesn't seem to be important. And so really what we're desperately needing now is clinical markers or biomarkers that will help us to individualize treatment, that we might be able to know from the start, is this a child who would benefit from the lower dose of steroids, or is there something about this child that tells us that they are likely to need to have intensified treatment earlier on? That's where I'm going to leave you. I don't know if I've left any time for questions, but I'm happy to answer any if you have.
That's wonderful, Martin. Thank you very much. And I wish you all the best with your application. Has anybody got any questions at all? If you'd like to pop them in the chat box for Martin. Just to point out, Martin's not going to be able to be with us later on for our panel, because you've got to go back to work shortly, haven't you, Martin?
I'm on call. If I can join back at the discussion, I will try to, but I can't.
Okay,
Sorry.
thank you.
Can I ask a very quick question when you let me? So Martin, what's your view on the, you've done the Predanos 2 trial was fantastic and looked at steroids at the time of URTIs. There are clearly other trials in the past that possibly suggested it was more useful. What's your personal view on where that's going and whether we've really answered the question?
I don't think I can say too much more until it's out in the public domain and published, but certainly the results are going to be interesting, and I think are going to ask more questions about it. I think that's probably as much as I can say at the moment, Moin, actually, and just leave people tantalising to come back and answer that another time.
Yeah, okay, we'll look forward to hearing the answer.
Sure.
Okay, thank you very much, Martin, for the update. That's wonderful. Thank you.
Okay, thank you.
If we can go to Richard Coward now, Professor Richard Coward.
Thank you, Wendy. Can you hear me okay?
Yes, I can hear you, Richard.
Fantastic. And
Thank
can you see my screen?
I can't see your screen yet, no.
How about now?
Yes, I can. Yes,
that's good. Brilliant.
That's lovely. Thank you.
Fantastic. Thank you for asking me to come and talk today, Wendy. I'm really pleased to be part of this presentation on World Kidney Day. It looks really good. So I was asked to come and talk to you about some work that we've done in the lab recently, which has identified a potential new treatment pathway for kidney diseases where you leak protein into your urine. And obviously that includes nephrotic syndrome. So this was an interesting bit of work that's gone on over the last probably 5 to 7 years. So it's taken quite a long time to develop. And it really is tales of the unexpected, because along the way, we've had a number of scientific discoveries where we've thought that our findings may have been detrimental, but they've actually been beneficial. And hopefully that will come through in the next 8 minutes or so. As ever, I'm one of the PIs, so I sit in my office most of the time and don't do the work. And the person who's done most of this work is Abeyagunawardena. And unfortunately, she can't be here today because she's on a training course. She'd like to have been, but she's asked me to present much of the work that she's done during this time. So I work in Bristol Renal. I'm the Professor of Renal Medicine. I'm also a paediatric nephrologist and have been through the Saleem mafia previously. However, what I've done is gone away a little bit from nephrotic syndrome to concentrate on another kidney disease called diabetic kidney disease. And this is, again, a disease where you commonly leak protein into your urine, and it's associated with diabetes. And the reason it's important is because it's the leading cause of kidney failure in the world. So over the last 15 years or so, my lab have developed a number of different models to really study diabetic kidney disease in great detail. And one of these models is looking at the podocyte cell that Gav's described very nicely at the beginning of this symposium. And what we've done, or what Abby's done, is basically made these cells diabetic in a dish. So she puts lots of factors like high glucose, high insulin, and other factors that go up in diabetes on the cells. And by doing that, we can then study their cellular response in a lot of detail. And the way we do this is we like to kind of go in with a completely unbiased approach. So we don't know what we're looking for. We don't go in looking for a specific target. We basically put it through a very sophisticated system and we see what it comes out with. And the system that basically has generated this work is something called RNA-seq. And this is a way that we can look at cells' messenger RNA, which are really important in the way your cells work, in a very detailed way. And we can put it through a machine now where we can look up to 22,000 different genes and see how they change. And we can do that in a couple of days. So again, just going back to some basic, I did O-levels, but I suspect lots of people did GCSEs, and how a cell makes a protein. So you have DNA, which is in the nucleus of the cell, so the middle part of the cell. And then that transcribes into something called RNA, which is seen here in yellow. And then RNA then makes the proteins, which are all the building blocks of the cell. And RNA-seq looks at this part. So this is the RNA. And as I said, it can look up to 22,000 different RNA signals in one go. So Abby did this on the podocytes in both a diabetic and a non-diabetic manner. And then she put it through the system, and she found that there was one particular messenger RNA signal that was much higher than all the others, and it's called NPY. She went through and did some statistical analysis, and again, this is basic maths, so people may remember p-values, and quite often a p-value in a statistical test less than 0.05 is significant. So this was the p-value that NPY came out with in this particular assay. And it's a lot less than 0.05. So she very sensibly decided to go and look at this in much more detail. So at this time, our hypothesis was that podocyte cells greatly downregulate, reduce the amount of NPY, and that this is a bad thing. So very little NPY will be a bad thing for the kidney. What was also interesting is NPY is otherwise known as neuropeptide Y. So it's mainly found in the brain. It's a protein, it's a very small protein, and it's the most abundant protein in the brain. It's not really described very much in the kidney at all. So again, that was a unique discovery that she made at that particular time. And what we found, and I'm not going to show you the data, but it is all in the paper, which I'll show you at the end. She looked at all the different cell types in the kidney and the glomerulus, and she found that the podocyte was the main source of NPY in the kidney. Again, this was a unique finding, which was really very interesting, and we wanted to follow up. So what she did then was she took the cells in a dish and she put NPY on the cells. So she put the protein that normally circulates onto the cells, and she tried to see whether there were any signaling events going on. So basically, you put the protein on the cell and you see whether the cell responds to it. She found very nicely that the cells really did. So this is just some analysis where we're looking at a protein which is called NFAT, which is a protein that is normally found in the middle of the cell, the nucleus, and it can move out of the cell in response to signals into the outside of the cell, which is called the cytoplasm. She found in the basal effect, so when there was no NPY on the cells, that the signal, which is in white here, was very much in the cytoplasm, which hopefully everybody can appreciate. But within 30 minutes of putting NPY onto the cells, this signal or this protein had gone right into the nucleus, into the middle of the cell. And that's really important because this protein can go in, join onto the DNA and cause different genes and proteins to be made. So it's like a master regulator of cell function. She also went on to look at other signaling pathways in the podocyte that may be responsive to NPY. And indeed, she found that there were two other systems that were switched on with NPY. So the first one was something called PI3 kinase, and the second one was MAP kinase. So she'd done some really nice work showing for the first time that NPY signals to cells in the kidney, particularly the podocyte cell. and she'd found that it started switching on a number of different systems. The next thing she wanted to do was to try and work out which receptor. So the way a protein signals to a cell is through a receptor. So it has to basically dock with the cell, and then all the signals can go from there. For NPY, there are 6 different receptors. So she looked at all 6 receptors, and this is showing you NPY receptor 1 in the podocyte. And what she found here was when she put the blocker of NPY receptor 1 onto the cells, there was no effect. The cells still responded completely normally to NPY. She then looked at NPY receptor 2, and this was very interesting because this time when she put the blocker on the cells, they no longer responded to NPY. So this gave her a really good clue that the way NPY was working in the kidney was through the NPY receptor 2. And again, that is relevant because there are medicines, there are drugs that can block NPY receptor 2. So what she then went on to do was to try and work out whether stuff that she was seeing in a dish could also be important in physiological systems. So obviously we are not cells in dishes, we walk around, we have lots of cells that talk to each other, we produce urine in the kidney, for instance. And what she did here was use a mouse model, a number of mouse models to try and work out the importance of NPY in respect to kidney function. So genetically modified mice have been around for about 25 years and have really told us a lot about biology and working out how systems work and developing new treatments to try and help patients. And for NPY, we were very lucky because there was an NPY whole body knockout mouse that was available that we could get in. And we first thought maybe the people that had looked at it before, because they'd looked at this mainly in relation to getting fat and obesity and diabetes, they hadn't looked at the kidneys in great detail. So the first thing she did was to look and see whether an NPY knockout mouse had any kidney problems. And the bottom line, they didn't. So again, this was not what we expected. We thought we'd find protein leaking into the urine of these mice. So that made us think that maybe the downregulation of NPY from the podocyte was a good thing, and the podocyte or the kidney cell was trying to protect itself. This is just showing that the knockout mouse model had no NPY as we'd expect because it had been totally deleted, and that basically the mouse model was not leaking protein into the urine. Again, every child with nephrotic syndrome has bucket loads of proteinuria. What she then went on to do was to use the medicine which blocked the NPY receptor 2 receptor specifically, and she gave this to mice, and then she gave them nephrotic syndrome. And again, very interesting, I'm just showing you a very small amount of the data. She found that there was protection of the mice who got the receptor blocker. So we thought this was really interesting and we're taking it forward. And then the final thing that she did, oh, is that right? Yeah. And the final thing that she did was so actually, sorry, I'm wrong about that. So what this one is here is she gave an NPY knockout mouse, she made that nephrotic by giving it an injection, and she found that the knockout mouse with no NPY in their body were protected from nephrotic syndrome. And then what she went on to do was just to look at the receptor, because this is where a drug could be developed potentially for using in patients in years to come. So she gave the mouse an NPY2 receptor medicine, and then she gave the mouse nephrotic syndrome. And again, similar to the genetic knockout, she found that these mice were protected from getting protein into their urine. And this is just measuring the amount of protein in their urine by using a very sensitive test. And as Gav showed you earlier on, if we looked at their filtration barriers, and this is incredibly important for nephrotic syndrome, the mice that had got the medicine had much healthier looking filtration barriers compared to the diseased mice. So in summary, my take-home messages are that we've discovered that this brain protein called NPY can signal to cells in the kidney, and when blocked, it reduces the amount of protein that leaks into the urine. And secondly, although these are early days, this could potentially be a new way to reduce urine protein leakage in a variety of different kidney diseases, including nephrotic syndrome. This is where the paper's published, and this is all freely available, so you can get the full copy of the paper if anybody's interested and download it from the internet. And then finally, just to acknowledge and thank lots of people. So again, really good science isn't done in one place. We did a lot of work with researchers in America for this, and these are some of their names highlighted here. And then finally, just to acknowledge lots of people who've worked in the UK and abroad over the last 15 years or so that are acknowledged here in yellow. All of the brilliant funding agencies that allow us to carry on doing our work. And finally, last but not least, the great team that have been doing this work over the last 10 or 15 years. Thank you very much.
Thank you so much, Richard. That's it's really exciting news, fantastic discovery. And we look forward to hearing more from you and the team. Thank you.
Brilliant, thanks.
If we could go to Sri Lanka now to hear from Professor Asiri.
Yep.
Hello there. Lovely to have you with us.
Yeah, can you see me now?
Yes, I can see your screen. Yes.
Yeah.
That's wonderful. I can see your slides now. Thank you.
Hold on, I need to get it to. Yeah, shall I do it like this? Is it okay?
That's fine. I think everybody can see clearly enough. Yes.
Yeah. Thank you very much, Wendy, for inviting me to speak on this World Kidney Day program. Today I'll be discussing regarding strategies to prevent relapse of nephrotic syndrome. This is the area I have been very much interested in my clinical research, and that is why I am glad that I'm able to speak on this. I'm actually from Sri Lanka, and I was trained in the United Kingdom at Great Ormond Street in renal disease. Relapse of nephrotic syndrome is one of the things that we would like to avoid in a child with childhood nephrotic syndrome, where the disease is characterized by a relapsing course. These relapses actually puts the children at risk of developing infections, thrombosis, and even hypovolemia, which can be life-threatening. And therefore, always we would like to avoid a child getting a relapse of the disease. However, when you get, at the same time, when a child gets a relapse of the disease, they do get high-dose steroid treatment, which again put them at risk of developing side effects related to corticosteroids, which is actually concern for the child, family, as well as to the treating pediatric nephrologist or a pediatrician. These relapse of the diseases are usually triggered by viral infections, mostly the viral upper respiratory tract infections, and occasionally from other infections, sometimes bee stings, vaccinations, etc. But what is known is that these relapses are because of a release of cytokines that believed to trigger an imbalance between the Th1 and Th2 immune system that triggers proteinuria. It is like actually a battlefield between two sides. One side, the doctor and the patient, and the other side, the disease. So it's like the conventional army on the left side and the guerrillas on the other side. Now, what can we do can be explained by this slide. So what we do in the initial episode by treating with high dose steroids is like carpet bombing. We just go and blast the way through. And therefore, we encounter a lot of side effects. And harder we go, probably there can be benefits. That is why a shorter course of steroids that was tried in somewhere in 1994, where we treated only until remission with daily steroids and gave 28 days of alternate day steroids, had more incidence of relapsing disease. And thereafter, as Martin quite rightly pointed out, there was accumulating evidence to say that more intense and longer versions of steroids can be associated with a higher proportion of sustained remission in these children. However, unfortunately, the newer studies could not prove that, but still, by giving 2 months of intense therapy, we can keep at least 25% to 30% of children in sustained remission after the initial episode. So that is important to understand that at least 2 months of steroids is necessary, and it is like a wholesale attack that we go and do. At the same time, we encounter side effects. So once we treat the first episode, then what is the other mechanisms that we can keep these children in remission? Levamisole is another drug that we use in the Asian subcontinent a lot, and United Kingdom as well, but it is not being used in the European countries very much. And levamisole is an anti-helminthic drug, which was used a long time ago, but now it is used as an immunomodulator. It is not an immunosuppressant as such. It is like putting a wall against between the two sides, so that whatever the attack that comes from this side is guarded here. So this is something that doesn't harm anybody, so you don't get much civilian casualties. So the levamisole is actually a very safe drug, not so effective though, but for children where it works beautifully and without much side effects. But at the same time, we use other mechanisms. Martin nicely explained about giving intermittent steroids during infections. Now that is, if you attack, I attack. So if you fire a shell, I fire a shell. So you keep both sides keep quiet. So that is what we do in this situation where we use intermittent steroids during infections. That has proved to help to maintain remission. So it is like you attack, I attack. Now at the same time, you can keep a sustained attack, continuous barrage of cells being fired from one side, that is from this side. So this side keeps quiet. So what is that maneuver? That maneuver is actually the use of regular steroids. You can use alternate day steroids on regular basis, or you can use mycophenolate mofetil, cyclosporine, or tacrolimus for that purpose. So all of these agents actually reduce the cytokine production. Now, by doing that, we continuously maintain a sustained attack. However, this comes with side effects, because if you keep on firing rockets, you're bound to get casualties on the other side. So we have to experience certain amount of side effects. So if you keep on using alternate day steroids for a longer period, as Martin pointed out quite rightly, you will get unwarranted side effects. Similarly, MMF or cyclosporine, which is a calcineurin inhibitor, has a catalog of side effects that comes with this drug therapy. But however, if the disease is not controlled, we will have to go with these drugs to maintain remission. But again, we have another opportunity. Once we treat the first episode, again, if the disease becomes troublesome, again, we can go back and do a bit of a carpet bombing. Again, it's a very harsh treatment, and you can expect a lot of side effects. That is what we do with cyclophosphamide and rituximab. Now, rituximab is a drug that has come recently, or about 10-15 years ago, but whereas cyclophosphamide has been used from 1967 or so to maintain remission. But today, I think very few pediatric nephrologists may be using cyclophosphamide as a treatment option. But what we have to understand is that before all this drug therapy came, it was prednisolone and cyclophosphamide that kept these children going. And therefore, in the Asian subcontinent, we still use cyclophosphamide because once you treat with either oral course of cyclophosphamide for 2 months or intravenous pulses on monthly basis for 6 months, at least 30-40% stays in sustained remission. They don't relapse at all. Of course, cyclophosphamide comes with a lot of side effects. Bone marrow suppression, opportunistic infections. But if we carefully use the drug, I think we can get a lot of benefit. So it's important I gain your attention towards cyclophosphamide because it's going to be a forgotten drug in the near future. So all this can be done if the parents contribute by monitoring their urine protein excretion. I think that is what is important, because if you detect the protein excretion early, then we can sort of immediately act on it and prevent a full-blown relapse. Whenever they get a full-blown relapse, they tend to have a more difficult course thereafter. So I'd like to conclude thanking again Wendy for giving me this opportunity. Thank you.
It's lovely to have you, and I love your slide, your combat slide. I think everybody can relate to that, being at war with the nephrotic syndrome, and we need as many medications in the war chest as possible. And I look forward to the day when we have precision therapies, targeted therapies for nephrotic syndrome. But thank you for the work you're doing. That's wonderful. Thank you very much.
I think, Sarah, you're next if you'd like to take the stage. Thank you.
Thank you.
Thank you very much. Something's gone wrong with my sharing, screen sharing. So just give me a minute or so. I'll try and get that sorted out. I'm Saraladevi Naicker, Professor of Nephrology and Emeritus Professor of Medicine at Wits University in Johannesburg.
Sarala, if you just minimize the Zoom screen you have. Oh, there we go. Thank you.
Can you see this now?
Yes, we can see it. Thank you very much.
Oh, brilliant. Thank you very much. Thank you very much for inviting us to present our experience of nephrotic syndrome, specifically via the Nephra study that we are conducting in South Africa. And I'm presenting this on behalf of our Nephros group in Johannesburg. Just to give you some background of nephrotic syndrome in South Africa, while the global prevalence is 4.7 per 100,000 children, it's been stated that there's a higher prevalence of nephrotic syndrome in African and Indian children. And in South Africa, it's been shown by various studies in children that steroid-resistant nephrotic syndrome is more prevalent, and the histology is predominantly that of focal segmental glomerulosclerosis. And initial studies showed a higher frequency of HLA-BW21, whereas with minimal change disease and steroid-sensitive nephrotic syndrome, the association with HLA-BW44 was reported. At the outset, my apologies for this very busy slide, but I just wanted to point out the large number of nephrotic syndrome publications from our pediatric nephrology group in South Africa. And I just want to direct your attention to this study by Bima et al. From Durban in 1997, where they published 636 children with nephrotic syndrome, equal number of Blacks and Indian children. And as you can see, a large number of FSGS in this group, 136 children, whereas 168 were shown to be to have minimal change disease. In the same year, Peter Thompson published a South African study of 720 children. And again, there were large numbers of FSGS, of over 290 patients in this group. The more recent publications, while of smaller numbers, also showed significant numbers of FSGS in this group. One of the things that recent groups in South Africa have been looking at is the genetics of steroid-resistant nephrotic syndrome. While it's been reported that there are over 50 genes associated with familial and monogenic steroid-resistant nephrotic syndrome in children and adults of autosomal recessive and dominant inheritance, and mutations in the podocin, nephrin, and WT1 gene mutations are common, especially with age of onset under 25 years. And there have also been studies on the ApoL1, G1, and G2 gene variants, which are reported to be associated with FSGS and CKD in African Americans. And just to suffice to say that in South African childhood nephrotic syndrome, this association was not shown, while we have shown very high association of these gene variants with HIV-associated nephropathy. So it does occur in South Africa, but not in childhood nephrotic syndrome. So just to report further on the podocin gene variants, the nephis2 gene encodes podocin that interacts with nephrin and CD2 associated protein to maintain the structural integrity of the slit diaphragm, which you've heard of very elegantly this morning, that acts as a filtration barrier. And the variant is a nucleotide change that results in an amino acid change from valine to glutamic acid. And these two South African studies recently in Durban and in Cape Town showed that the Nephis 260E variant was present in steroid-resistant FSGS, but was absent in those children with steroid-sensitive nephrotic syndrome. And it's been postulated that this gene variant alters the podocin protein, preventing movement of the protein to the plasma membrane and affecting the structural integrity of the slit diaphragm. And the Johannesburg group further showed the kidney survival in those with this Nephis2 variant. And as you can see, the survival has been considerably shortened in those with the variant compared to the steroid-sensitive nephrotic syndrome without the variant. Now, just to tell you a little bit about our Nephros study in South Africa. We've recruited 195 patients to date, mainly children, 106 Black children and 61 adults, mainly Blacks, and a smaller representation from the other ethnic groups in South Africa, which I suppose is a representation of our population in South Africa. And controls, again, match controls were accordingly looked at, and the gender in males, mainly in children, mainly male, whereas in adults, there were equal numbers of men and women. The next few histograms show the age of onset of nephrotic syndrome in our adult and pediatric recruits. These show the age of onset in the children and the stage at which we recruited the children onto the Nephros study. And in adults, similarly, the age of onset and the age of recruitment a few years later. And looking at the histology, you could see that in pediatrics, while the predominant histology was minimal change disease, with just over 28% of FSGS. In adults, the proportion changed with more FSGS at 62% and 31% minimal change in the cohort that we had recruited. And looking at the ethnicity, one could see that FSGS was a predominant histology at just under 50% in our Black group, whereas looking at minimal change, again, a similar proportion at just over 46%. Interestingly, the other race groups showed more minimal change disease, but as you see, the numbers here are very, very low. But important to mention this because this represents what has been published in previous studies in South Africa. And looking at the steroid responsiveness, one could see that steroid-resistant nephrotic syndrome was in the group that we recruited, occurred in just under 30% of children, and a similar group in adults, whereas the steroid-sensitive nephrotic syndrome was present either fully steroid responsive or various proportions of steroid dependence with frequent relapses in over 50% in both children and adults. Just to tell you a little bit about the projects that are nested in Nephros, we currently have 2 PhDs that are nested in this group with a further few in the proposal generation stage. The current 2 are spectrum of nephrotic syndrome in Black African children over a 35-year period at Chris Hani Baragwanath Hospital, the largest hospital in Africa. There's an interesting cohort of congenital nephrotic syndrome that's nested in this. And this is a PhD of Professor Uday Kala, pediatric nephrologist. The other study, looking at pathogenesis of idiopathic nephrotic syndrome, looking at the maladaptive response to Epstein-Barr virus infection, is a PhD of Professor Graham Paget, an adult nephrologist. The challenges that we faced with Nephros were changeover of our research team, a very frequent changeover, and of course, the COVID pandemic last year really put a halt to both recruitment of patients and controls when clinics were actually not running for most of the year. So in conclusion, I'd like to thank the participants in the study, the staff at the clinics who assisted in recruitment of patients and controls, and our research team, with special thanks to our scientists, Confidence, Nicholas, Kiashni, and the nephrology fellows, Waziri, Morgan, and Aisha, who were superb in recruiting. And a very big thank you to the MRC UK and the Bristol team for support and funding. Thank you very much for your attention.
Thank you very much for your update on your research studies, and it's wonderful to see everybody being very collaborative in their research. You know, you're working with Bristol and also Sri Lanka as well, and thank you very much.
Thank you, Wendy.
So we're whizzing now to London, and hopefully we have Dr. Ania Koziell online.
Yeah, you have me.
Hi.
I'm gonna start my screen share. And at the moment, it's not working, which is a bit annoying.
Oh, right.
It's yeah, because I'm doing screen share.
Like us to go.
Let's see.
Get Rachel online.
Wait, no, it's okay.
Okay,
we got it. We got
Fantastic.
it.
Fantastic.
I think I've been using it quite a lot, so it kept flashing up with my whiteboard. I think I probably wouldn't want to draw my talk from scratch right now. Anyway, Wendy, thank you very much for inviting me. This is a bit of a sort of
lovely to have you.
I'm going to be talking about a liposorber, which is a new treatment, or perhaps not so new treatment, but a new treatment for the UK, which is a little bit of a St. Jude treatment for, as we have alluded up till now, the patients where your carpet bombing has not worked, and you need something more. Because otherwise, unfortunately, there is only the one outcome, which is sort of dialysis and transplantation. We all know that this is a problem, and nephrotic syndrome in its many guises is a prominent cause of kidney failure in children and adults. Clearly in adults, diabetes has overtaken, but in children it is still FSGS because diabetic nephropathy is rare. And the big problem is, unlike some of the other diseases that you get in childhood, transplantation isn't a complete answer, because unfortunately the risk of disease recurrence post-transplant is very high. So, and once you've recurred, you recur again and again. And so the whole kind of gist of this is to try and prevent that happening in the first place. At the moment, our concepts of nephrotic syndrome, we're always talking about nephrotic syndrome, but to me, I think it's much more of a sort of spectrum of diseases. It's a spectrum. We're just describing. It's what it says on the tin. It's a triad of symptoms where you swell up, you lose because you've lost protein in the urine because of a kidney problem, and on top of that, you also get high lipids. And you've got on the one side, you've got the genetic types where you can identify a gene. These eventually will end up in end-stage renal failure. But the good thing is, in some ways, if you have got this type of nephrotic syndrome, if you do have a transplant, there's a very low risk that the disease will recur. Nonetheless, circulating factor disease is the more common when it comes to steroid-sensitive nephrotic syndrome. There's a low risk of end-stage renal failure, but unfortunately, if you do not respond to treatment, there is a high risk of post-transplant recurrence. So this is the group we've really got to do something. And my little bit at the bottom is where you've got the sort of, you're always as a clinician juggling the drugs you use to try and limit the protein, limit the disease from progressing, with the effects that they may have on the body. I'm going to sort of propose that perhaps that we need to be thinking it in a less binary terms. And certainly the group that we treat with liposorber, very much what we call the complex nephrotics. These are patients who do not respond to treatment and have a high risk of recurrence post-transplant. And in many cases, the clinicians are just going, now what? What do we do? What do we do? And I think there's one aspect is to address the research and how we can actually identify these patients better, institute treatments better earlier, but also what can we do to understand the disease and how can we prevent it coming in the first place. One thing that we have done with genetic studies is to identify this group of patients are less likely to have a gene mutation. Then they're what's called a complex trait. There's more than one gene involved. There's an environmental impact, and there seems to be a role for immunity, the immune control box in the body. For some reason, it doesn't exactly go wrong, but it has a variant which predisposes you towards nephrotic syndrome in the first place. And then other things probably happen. This is just a very busy slide. It's really to illustrate that whatever the cause of nephrotic syndrome, the target for injuries, the podocytes, however, there are a myriad of things that can happen. And so it's the drugs that we use are very much targeted to the processes that we've identified that may go wrong. However, when it comes to things like liposorber or plasma exchange, in some ways, it's a very sort of simple approach. Basically, you take the plasma out and you either put new plasma in to try and counteract the effect of the circulating factor, or you actually take it out and clean the circulating factor out. And that's the sort of crux of liposorber. So basically, it's a repurposed technique. It was invented for high cholesterol in the blood. There are lots of genetic causes of high cholesterol, and the main baddie in the disease is LDL cholesterol. And the apheresis is basically a way of cleaning the blood and cleaning out the LDL so that your cholesterol can come down and it stops attacking the rest of your body. What you have in nephrotic syndrome, particularly in adults, is that you generally do have, as a byproduct of the nephrotic syndrome, high cholesterol. So in Japan now, maybe 40 years ago, maybe more, people started using LDL apheresis to try and treat the high cholesterol people saw in nephrotic syndrome. But as a byproduct, they noticed that the nephrotic syndrome in these patients was beginning to resolve. which is quite a surprise because no one really thought about it in that way, nor was it being used for that purpose. And then in Japan, they started using it in children again from the 1990s. What is quite nice about the technique is it is quite safe. There's virtually no complications other than you do have to have a line inserted. And it has been used both pre-transplant or post-transplant, and really for some years. It's just quite new to the UK and the US. You basically need a machine, you need a tubing, you need a couple of filters, and a plasma, what's called a plasma separator to separate out your plasma, and some fluids. You need a technician, a willing patient, and a doctor that's willing to try it. And then basically this kind of slightly complicated diagram just shows that really what's nice about this technique is you don't put anything back into the patient. You basically take the patient's blood, clean it, clean out the bad substances or molecules, and then put the plasma straight back in. What's special about the type of filter we use, not all LDL apheresis works for nephrotic syndrome. This one has not only a size selection, so it sort of identifies various sizes of particles, but it also has charge. So some of the problem of nephrotic syndrome may be that the glomerular basement membrane has lost its charge, or the charge is altered. So proteins that should go out, or substances that should go out, should not go out, rather do go out. And we think that maybe this recapitulates some sort of mopping up of whatever the circulating factor is. What it does do is filter out lipid, but also there's a lot of evidence to suggest that there's also immune active molecules that get filtered out. And interestingly, also increases some protective molecules that stop protein from leaking out. As I mentioned, there's a lot of data. This is Japanese data from 2 to 5 year follow-up. And essentially, rather than the sort of likelihood that the majority of patients will go on to end-stage renal failure, relapse post-transplant, or have a transplant relapse, this seems to turn around something so that your chance of success is much more like between 50 and 60%. And what they describe by type 1 incomplete remission is basically reducing your proteinuria such that your kidney can survive for quite a long time, until such time as, you can grow a kidney in a dish, or there are better treatments for nephrotic syndrome. So at least it helps your kidney to survive longer, prevents transplantation from happening, and end-stage renal failure from happening, until such time that events occur and the kind of knowledge and research catches up such that we can actually give molecules like Richard's presentation or other treatments that can prevent disease progression. Who might benefit? Where it's been used is basically post-transplant disease recurrence, and there's the most data is on that. And basically at the moment, it's used when there's no response to plasma exchange, because that is the mainstay of treatment with post-transplant disease recurrence, and it works quite well in some people. It's really very much related to the degree of protein lost, and whether you respond or not, and quite how quickly you develop the post-transplant disease recurrence. So it may or may not work, and the jury's very much out. It's 50-50 either way, I would have thought. But actually, overall, the success rate for plasma exchange is no more than 20%. The pre-transplant patients, again, it's really very much the domain of those patients who have not responded to anything else, or for reasons such that, for example, I have a patient who has an additional kidney condition, so I cannot give him things like tacrolimus. There, if what I'm treating with does not work, then liposorber may be a solution. And also there's quite a number of papers now appearing that patients who are at high risk of post-transplant disease recurrence, so these are patients who've got a past history of steroid sensitivity or other drug sensitivity, even transiently, you can't find a gene or previous transplant recurrence, people have treated quite successfully and prevented the relapse happening in the second graft. I think the most important thing is that you can't use this technique as a salvage. Like anything else, you've got to start or consider it before there's embedded chronic kidney disease, because and we use arbitrarily a GFR of more than 60, but that's just a guide. We've kind of modified the protocol a little bit. This is the original protocol that went through the FDA some years ago now, where you start off with twice a week liposorber for 3 weeks, and then drop down to once a week for 6 weeks, and you add in quite a lot of prednisolone. We've actually then modified it. So rather than giving rather a lot of prednisolone, because the next rescue protocol actually gives 2 milligrams per kilo per day, prednisolone being quite, steroids being quite toxic for that length of time. instead we give IV methylprednisolone at a lower dose. We actually just keep the patient on whatever steroid dose they happen to be on. And we've actually increased the liposorber in those subsequent weeks for twice a week, because we can see we can get away with it that way. We don't have to give the amount of steroid that other groups may have done. There are a number of types of outcome. You can get complete remission. Your PCR goes completely back to normal. This doesn't, irrespective of whether you're pre or post transplant. You can get a partial remission, which I sort of describe as between, well, probably less than 1 gram per, so a PCR of about 200 to 300. And you can get that in about 25 to 30%. And that again buys you time until such time that research developments occur and maybe there's better treatments that can reverse disease. You can also get complete or partial remission. You get a little bit of liposorber dependence. We found that in some of our patients, that you do still need to continue liposorber for once a week. But again, this technique and the data surrounding this technique is new. So we don't know whether that's a lifelong thing or whether it's just a transient thing. But again, once a week treatment for something that is really very well tolerated is far better than 3 times a week hemodialysis or transplantation. And people have seen delayed responses. There's a paper circulating around where they've looked at 5 patients where initially the patients didn't respond, but then did subsequently. And actually Rodney Gilbert has seen the same when treating a patient down in Southampton. And unfortunately, as with any disease, about 10 to 15% don't seem to respond at all. But at the moment, we can't identify who those people are. I think really the summary is it's not a magic bullet, but it is an important further option. And I think the other important things that clinicians do not wait too long. It does not work in established chronic kidney disease. And it's better to get the patient before they go down that very negative trajectory of a bag of drugs, millions of diuretics, horrific edema that you need filtration to remove, and daily 20% albumin, and you've already developed some acute kidney disease. And actually, one thing that I would say, like with any other treatment in nephrotic syndrome, if you've actually even made a transient response to something, your prognosis with this is much better. So if you've had a little bit of a response to tacrolimus steroid, it doesn't really matter what, you may do better. And then post-transplant, I think it seems to be working a little bit better, but it's probably because the disease is not as embedded. Normally we get patients when they're 2 to 3 months into a recurrence, so the kidney is not quite as damaged by the nephrotic syndrome as yet. I just will finish off by 3 cases, examples of a post-transplant recurrence. This is a complete treatment resistance FSGS recurrence, occurred soon post-transplant. Everything was tried, all the conventional treatment. And we followed, because this was our first patient, we actually followed the rescue protocol. This with slightly less prednisone, it has to be said, for 12 weeks, and then we stopped. And basically this, we could see that there was a response at 5 weeks, complete remission by 12 weeks, which just continued to improve. And at 3 years down the line, this patient has a normal creatinine, normal graft function, normal albumin, and normal protein creatinine ratio. And that is a far better quality of life scenario than perhaps she would have faced had the plasma exchange continued. This is not so new. We've now published this data. It's actually a slide pinched from Dean Wallace. It's not one of my patients, but I thought it was quite nicely shows that actually it's not just our center that's had success with this technique. Case 2 is a pre-transplant steroid resistant patient. It's basically, this is a patient that you typically see that you try everything and there's little to no response. And some years down the line from the diagnosis, maybe 2 or 3, maybe longer, you've basically got a nephrotic syndrome that's poorly controlled with PCRs up in the thousands. Creatinine hasn't quite started to rise yet, you know it will, and you've run out of options. So with this patient, we also started liposorber about a year ago now. I think this was a very informative experience. We did learn that repeated infections need to be sat on quickly, because like with any type of nephrotic syndrome, any infection just makes it worse. So we now have a protocol that in patients who are susceptible to infection, we start prophylactic antibiotics and IVIG. We did try rituximab somewhere down the line. In fact, it hadn't worked before and it didn't work at that time. And we have found that over time, things have improved, but we do need to continue liposorber once a week. So every time we try and wean, the PCR goes up. But again, this is a patient we've continued over the 12 weeks. We're now at 1 year. However, if you see the progress, we've gone from a mean albumin of around 20 to 21 to a mean albumin of 30 to 34. And the creatinine has not deteriorated, the GFR is about the same. So whilst I wouldn't say we have complete cure here, we're probably going to be able to stabilize this patient sufficiently such that he will be okay until maybe there's other developments, or it may improve further, because if you look at the 5-year survival in the Japanese patients, these patients do improve with time. And that's been really the basis for continuing treatment. And again, he's on low-dose tacrolimus, MMF, low-dose prednisolone, and once-a-week liposorber, which again, I think is quite a good quality of life. And also, we've also improved lots of things like anemia, vitamin D, cholesterol, and his growth has improved from less than second centile to now growing above the 25th. Case 3 is a secondary steroid resistant. This is a patient who has responded to treatment, but then lost response some years down the line. All conventional treatment, including obinutuzumab, had been exhausted, and he started liposorber about 7 months ago. He made a fantastic response. However, this young lad also doesn't take his drugs. So every time he stopped taking his regular medication, he relapsed. Again, we're looking at a disease that's been embedded for some years now. He then got COVID, and then he relapsed. But every time we've actually restarted liposorber, we have salvaged the situation. And in fact, the first time he relapsed, we did try steroids and it didn't work. So whether he was taking them or not is another matter. But again, liposorber is a safe, easy way, once you've got a line in, to just get things going. We've just actually weaned him to 2 weekly, and we're planning to try and stop. Again, he does remain on his regular medication, but instead of completely bombing with his GCSEs earlier last year, because he was feeling so ill, he's managed to retake them all and has got 6s and 7s for most of them, which is again very important for a lad's future. So really, in conclusion, I think we've got to think about liposorber in these patients, which are complex, have not responded to anything else. I think the key thing is not to refer too late. And I think it's very, I'm working closely with a group in the States, and I think the post-transplant patients seem to be a little bit easier to treat than the pre, but again, it's a case mix. The duration of nephrosis is shorter. It's a little bit, we don't really have the data yet. I think 9 weeks is probably too short, but by 3 or 4 months, if you have no response, then it's not really working. And I think you've got to sort out all the first acute complications. I think we've learned that we've got to sort out the gross edema, hypertension, acute kidney injury. We've got to get the patient in as normal a physiology as possible before starting. And then we also address all the other issues that come with long-standing nephrotic syndrome. And that we've noticed that does aid recovery as well. And then preventing infection is key. I think it's informed our protocol development. We now substitute all that extra steroid with twice weekly liposorber, which is far more pleasant. Because again, it's a short technique. It lasts 2 hours. It's not like going into plasma exchange or dialysis. You're in, out, 2 hours, and you do not feel ill when you have the treatment, because it's very non-invasive. And continuing really conventional treatment is important for the secondary inflammation. If you are struggling with post-transplant cases, you can use plasma exchange as an additive. And it is quite good for relapses once you've been on liposorber, as we've discovered with our patient. And then I think with partial remission on once-a-week liposorber is going to be infinitely less life-challenging than 3 times a week hemodialysis, and does appear to buy you time. So future directions, I mean, I think the key thing here is we really don't know why it works. So the plan is to do lipidomics on plasma we have saved. It might help us identifying the circulating factor or factors. And I think at the moment, we've got to look at bigger clinical cohorts, perhaps internationally, to really develop the right protocol to establish who might best benefit and for how long we need to treat. And luckily, one boost is that we are developing a dedicated LDL apheresis centre over at Guy's and St Thomas's, which will be treating children and adults. So thank you for your attention.
Wow. Thank you very much, Ania. That was very comprehensive.
I'll try to squeeze it into 10 minutes, but there's a lot going on.
But isn't that so exciting, everybody, especially if you yourself's got FSGS, or you're a parent of a child who's got FSGS. There's something else out there which can be used, and it's obviously imperative to be used at the right time. And I look at looking at the future. Very interested to hear more studies that come out, Ania, so keep me posted, won't you, please?
I will do. Yeah,
and so this type of treatment's limited in the UK at the moment, isn't it? There's only a few centres, paediatric centres using it. I don't believe there's any adult units using it at the moment, are there?
No, I mean, I mean, Dean's using it up in Manchester, Rodney down in Southampton. We're planning to roll it out at Guy's because you've got this benefit of LDLA. We're going to become the LDLA apheresis centre for London for anything that needs that kind of thing, and kidneys are kind of part of it. And Imperial are starting to consider it as well. So I think the word is spreading. It's not new, and I think if you're selecting the right cohort, it is a very powerful tool. It's just when you start to lump in, cases where people are going, oh, we've tried everything else and things have gone really bad, so let's try this as a last off. I think that's not fair on anybody, actually. But I think it is spreading. The word is spreading. I think it's certainly Manchester adults are also quite interested, according to Dean. So fingers crossed.
Yeah, thank you so much. Thank you. And so we go up north now to, is it sunny Manchester?
Yeah,
it's today.
Manchester, it's not raining at least.
Oh, good. Lovely to have you with us, Rachel.
Thank you, Wendy. Thank you very much for the invitation. Yes, and thanks, Ania. We are certainly getting some experience of the liposorber up here with Dean leading on that. Yeah, thanks for the invitation to talk today. I'm going to just talk about how we can get more information from kidney biopsies, which of course many patients with nephrotic syndrome have. I'm a paediatric nephrologist up at the Royal Manchester Children's Hospital and also a kidney researcher at the university. So I'm just going to reinforce what you've heard lots about already this morning, about this fantastic kidney filter, which comprises unique cells and matrix. So we've heard a little bit about the basement membrane structure in grey here, which is the scaffold that these beautiful podocytes sit on. So this is a podocyte in its full glory that we've captured using electron microscopy, and then we've modelled the features of this particular cell, and you can see just how beautifully complicated it is. So it's not surprising that when it doesn't work, we see problems from it. So what we focus on up in my lab in Manchester is on the scaffold, on the matrix that these cells sit on. And actually, when we look at when we've looked at the composition of this matrix, this scaffold, over a number of years now, using a specialised approach called proteomics, we defined this really complex network of proteins. So over 140 proteins that are important in this scaffold structure in the glomerular filter. And when we think about kidney disease, then what we do know and have known for decades now is a number of the different patterns that we see under the microscope. So when you have a kidney biopsy, and that gets prepared in different ways so that we can look at it in different ways and with different microscopes. And so using a light microscope, we can see a normal kidney filter, but then these abnormal filters in a number of different kidney diseases and glomerular diseases. And I think there was a question there from Sheena in the chat about research in adult nephrotic syndrome. And of course, membranous nephropathy is the commonest cause of nephrotic syndrome in adults. So we can see these patterns under the microscope, but we actually don't know a huge amount about what drives these different conditions. But what we do see is that matrix, the pink stuff, there's plenty of it, and it accumulates in both membranous, in FSGS, and in other glomerular diseases. And we can use the electron microscope to go even further and zoom in further into the kidney biopsy to see what things look like. But the missing information is what's changing in all of these proteins that are in the kidney filters. So that's one thing that we've been working on now for a number of years, looking in normal, which is where we started, and then more recently looking in abnormal kidney biopsies and kidneys from mouse models. So we're often limited in the amount of tissue or sample we can get from human kidney biopsies. So in research, a really important and useful way for us to understand more about a disease process is to study mouse models. So this is a really complicated slide, but what we did over a number of mouse models, and also looking at human kidney during aging, and this was with donated kidneys that weren't used in transplantation, we were able to define a signature of abnormal kidney matrix, and that paper's just under second review in one of our kidney journals. So the purpose of this is that we might be able to identify early changes. If we biopsy early in a disease process, we might be able to identify early changes and biomarkers that could help us tailor the treatment for individual patients. So we started this whole process taking as much kidney tissue as we could, but we've now really tried hard to miniaturize and go smaller scale. And so I just very briefly wanted to introduce to you how we're using lasers, microscopes to enable further kidney exploration. And Michael in my lab has really pioneered this approach, where he is able to capture these beautiful pictures of kidneys. You can see some of the elaborate structures here. And he's progressed to use what we call a laser dissecting microscope. So it's a microscope that allows you to identify a piece of tissue like this filter. So this is a glomerulus. And then we use a laser to cut around it, to separate it from the tissue that it's in. And then that jumps up and it gets caught in the cap of this tube here. And so you accumulate your samples here. And then what we do is we treat those samples so that we are able to reduce them down into individual proteins, and then even smaller into individual peptides, which are what proteins are made up of. And then we can analyze that those samples in machines called mass spectrometers, which then give us a readout of all of the proteins in there. And we were really surprised by the level of detail that we could establish. So what this allows us to do is take a tissue, whether that's healthy or diseased, and turn the tissue into a series of proteins that we can understand more about in terms of how they might be contributing to a disease process. So this is my kind of final data slide, really, just to say that we've started doing this now in nephrotic syndrome. And this is part of the Nurture study that you'll hear more from in Moin's talk coming up next. And we've been receiving in Manchester kidney biopsy samples from patients with nephrotic syndrome in the Nurture study. And Emily, who's on the call today, is literally is in her first month in my lab and is going to be working on this project. So we've got biopsy samples from patients with minimal change disease and FSGS. And what Emily is going to be very carefully doing is dissecting those glomeruli and working out the best way to get the best information from them. And we know amongst the group of patients that we'll be seeing biopsies from that they've had a number of different treatments. And so we'll be able to not only look at the proteins, but potentially look at effects of different treatments or different types of nephrotic syndrome that these patients have had. So we're really excited to see where that takes us. We have a parallel study in Manchester that is already underway, doing exactly the same thing in membranous nephropathy. So these patients are predominantly adult. And then we also, really important that we're able to control that and look at normal samples. So we've got a control data set as well that we're establishing. So this is the process that we'll run through over the next few months. And I hope by the time we get to July, which is where when we're hosting the 13th International Podocyte Conference in Manchester, that we'll have some more updates in terms of kidney biopsies and nephrotic syndrome. And there's a patient meeting that you're all very welcome to join and come to on Saturday, the 31st of July. And Wendy's heavily involved in helping us to organise that. And then I'll just finish up by saying thank you, just as I don't do this hard work, as Richard said, it's a huge team behind the scenes. And also, of course, you know, the research that we do would not be possible without our research funders. So just a very quick introduction to what we're doing up in Manchester, and very happy to take any questions.
Thank you so much, Rachel. It's very interesting.
Good. Do
you have many patients donate their kidneys in Manchester Hospital?
Yeah, so I mean, we have a huge transplant program in Manchester, and some of those kidneys, for technical reasons, just aren't suitable for transplantation. And so we are then fortunate to have access to those healthy kidneys that aren't going to be used in any other way for research. So that's really helpful for us to be able to study normal kidneys in different ways.
But also sometimes kidneys are taken out of patients, aren't they? Pre-transplant,
yes,
to raise the albumin levels, like my son. I know we donate to the kidneys, so that's also helpful as well, isn't it?
Absolutely, that's really important, Wendy. I mean, one of the things that in that scenario, the kidney often has become very scarred, and so what we're able to do, we can learn more. We can learn about what the kidney is like at that stage of the disease, but it's often very far into the disease process. What's more of a challenge is getting information from samples at, you know, the earlier part of disease, and that's where the Nurture project and the biopsies, I think, are going to be really, really interesting to see where we get to.
Yes, that's right. So for people listening in, that those samples are absolutely crucial to the Nurture and Nephros studies. So you know, the team are looking for plasma samples, kidney biopsy samples, blood and urine. But Moin's going to tell you all about that next. So thank you, Rachel. Thank you so much.
Thank you.
And so I think take it away, Professor Moin Saleem.
Okay, and it's been fantastic. So well done everyone for organising. It's been really nice to see, especially all our international collaborators. It's so nice to see you. So I'm going to, aware that we're kind of running slightly behind time, so I'm sort of going to try and give you a brief overview of Nurture. So Nurture is a kind of cohort study that's built upon the radar and Nephros studies that you've already heard about to some extent. And I'm going to try and move my slide on, would be nice. Sometimes, there you go. So these are cohorts that are built around the disease primarily of nephrotic syndrome, but we're also looking at chronic kidney disease. And the Nurture cohort is premised on building on top of the existing registries of Nephros and Radar, particularly to collect very carefully collected biosamples. So as you've heard from Rachel and others, how important these samples are. And the international Nephros, this is World Kidney Day, so the international Nephros is particularly important as well. And it's been modelled on the Nurture platform and protocols, and that includes Asiri from Sri Lanka, our South African colleagues, Saraladevi, and so on. So some really key collaborators there. And it's an industry academic collaboration. We've got currently quite a lot of funding from industry to build the cohort, and some in-kind contributions as well to do things like sequencing of genes. And in the UK, we've got 16 sites recruiting patients, very strictly what we call industry standard biobanking, where we collect and aliquot samples when they visit for their study visits. And so far we've recruited 3,000 patients with chronic kidney disease, and 800, and the aim is 800 patients with nephrotic syndrome, and that's currently slightly delayed due to COVID, but we're over 600, so doing really well. And there's an opportunity to collaborate between all these people across the world, but here and elsewhere, to utilize the data that we're collecting and the samples to really accelerate the research. So just very briefly, so Nurture is a prospective study for these 2 cohorts, and it's a platform. We're trying to build a platform so that research can go on and go forward into the future. And we're collecting plasma, serum, urine, DNA, renal biopsies, and making sure they're available for research. And the plan was for rapid recruitment, which was why it's really important to get the funding and utilize the databases in the UK to obtain really comprehensive data of the clinical features of the patients, because it's really key to align the clinical features with all the biology that we can learn from the samples. And the aim that we want to get to overall, and it's quite an ambitious aim, is to reclassify the disease of nephrotic syndrome. So we want to move away from these observational labels that we're all talking about, and get to a classification that's based on the underlying, if you like, a molecular signature of disease, based on all these kind of molecules, like the molecules that Rachel's talked about in the biopsies, the genetic markers and so on, that will tell you exactly for each patient what signature they have of disease. And so the opportunities are to sort of change the landscape of disease. The current treatment, as I say, is trial and error, and you've heard about that, and some trials have done really well, like the Prednos trials, but other trials are just trying things and seeing whether they work. And they can often be unsuccessful. So we need to sort of rethink the classification and base it on these new biomarkers. And so what we want to do is stratify patients by the mechanism of disease. And what I'm showing here is some of the different mechanisms, the levels of mechanistic insight that we're trying to get. So we're looking at genes, what's called the genome. We're looking at the epigenome, and I'll tell you a little bit about that. Transcriptome, which is a bit like Richard talked about, looking at the RNA level. Proteome is what Rachel told you about, which is at the biopsy level. We look at proteins, and metabolome is a separate thing where you can look at the profile of plasma, blood plasma, and that might relate, for example, to the work that Ania talked about. And so what we want to get is allocation of the right treatment to the right group of patients at the right time. That's the aim of so-called precision medicine. And if I kind of illustrate this very simply, this is what we're planning to do then, and I've started doing already, is to look at each biomarker individually in each patient. So you look at the genetics, what's in the plasma, what's in their RNA, and so on. And you end up with different patterns for each of those biomarkers in each patient. And if you line up the patterns, what we hope is that these patients will end up in specific groups according to those molecular features. And if you've got those specific groups, then you can line up and say, well, which patient is going to be treatable by which treatment, and also that you can show you can discover the mechanisms and find new treatments for those specific groups. So very briefly, again, I won't go through this in detail. Currently, you can stratify out patients according to their clinical response to treatment. So we have our steroid-resistant patients, we have our steroid-sensitive patients, and some of these patients who are steroid-resistant in particular get recurrence post-transplant, and we call that the circulating factor disease group of patients. And you can predict those groups, for example, by secondary steroid resistance in this group of patients. So we can make some kind of insight into what the different categories might be. What I just want to illustrate one piece of data which is showing that we can sort of start to change that landscape by looking at specific aspects of disease, of the molecular pattern of the disease. So this is called the epigenetics. Now the epigenome is so you have your genes, and your genes don't change in each individual, or our genes are set for life. But in epigenetics, you can modify those genes chemically, and that modification can be switched on or off during life. And if you modify the chemistry around the genes, you might alter the function of those genes, and that's what the epigenome means. And you can measure that. You can look across your whole genetic sequence and see whether those chemical modifications occur. So that's what we've done. We've looked at patients' epigenome with nephrotic syndrome, so to see whether patients have that chemical modification of their DNA in specific genes. And what we did is we picked 4 groups of patients. We picked patients who have a genetic cause for their disease, so that as Gavin showed right at the beginning, if you've got that spelling mistake in your gene, that's your genetic group of patients. Then there's non-genetic groups, but who have steroid-resistant nephrotic syndrome. There's steroid-sensitive groups, and there's this group that we think have a circulating factor disease. And we took their DNA and we did what's called an epigenetics chip. We ran a chip where we can look at that chemical modification across their that DNA profile for each patient. And what we then do is to look at the profiles of those chemical changes across the genes. So there's lots of mathematics that goes into this, but the kind of long and short of the results is that what you can see is these epigenetic profiles start to group out. So each individual point on here is a single patient, and these are the patients who had genetic disease in green. These are the patients who had our circulating factor disease in blue. These are the steroid sensitive patients, and the yellows are the non-genetic steroid resistant patients, which have some degree of overlap, suggesting that some of those patients might have a circulating factor disease, some might have a genetic disease that we haven't yet discovered. So really nicely, these are separating out into groups that suggest there are different mechanistic categories. And if we can carry that on, so we're now expanding that to a larger number of patients, you can start to see how you might get a signature, an epigenetic signature, which will put a patient into a group that will tell you how they might respond to treatment or how their disease might develop. So that's how one example of how we're using all these samples and all the data to really dig deep into reclassifying disease. I probably haven't got time, but another aspect that touches on what Gavin was saying in the lab is that we're using our in vitro models, so the models in the lab, to develop podocytes and glomerulus structures in the lab. So this is a spheroid, which is a glomerulus structure that we can grow in a dish. And you can use that to put patient plasma samples on and look at alterations in the podocytes, in particular in the health of the podocytes, to show, and you can then treat them with specific drugs in the dish again to see whether that has a rescuing effect. So that's all really nice ongoing work to start to keep stratifying these patients according to what's in their plasma samples. So in conclusion, I think Nurture is a really powerful opportunity. It's driven primarily by patients, by patient groups, clinicians, and charities such as Nest and Kidney Research UK, giving us fantastic new insights into the biology of the disease. Rachel's going to do proteomics on the biopsy samples, as she said, and we're going to get more information on the genetics. And hopefully that will lead to new diagnostic tests, treatments, and this precision medicine approach for each patient. And there's loads and loads of people to thank, and I apologize if I've missed anyone, but clearly a lot of people on this call, international collaborators in particular, who've been amazing, and Wendy and the patient groups who really drive what we do. So thank you for listening.
Wow, that's fantastic, Moin. I'm really encouraged by all the research that's going on at the lab. It's phenomenal, and I sit in many meetings, as you know, and I just want to share with patients out there that I'm just so inspired about what's going on at the moment, and I'm very excited of all its discoveries, and hopefully one day we'll have those new therapies which can be used for patients. So we come to our time of questions. I don't see too many in the question box. I don't know if anybody wants to add any more questions for me to pose to the panel.
So
I think
one's
been answered. Yeah, can you see that one there you can answer, Moin?
I just saw one that popped up as, can I be referred to Nurture? So Nurture is being run across, let's say 14, more than 14, maybe about 16 large sites in the UK. If you happen to be being treated in one of those sites, then you should very much approach your clinician to be enrolled if you haven't been enrolled. And if you look on the website, so it's nurturebiobank.org. I'm pretty sure, Wendy, that's got a list of all the sites, hasn't it?
Yes. Yes, I'll put the link down in the message box shortly. If I can scroll up and go to the question on circulating factors cleaned by the lip absorber, and I think the person's asking why doesn't plasma exchange work, but wants to know about the factors which are cleaned from the lip absorber. Ania, could you answer that question, those two questions, please?
I can try. I mean, the two techniques are slightly different because what lip absorber does probably is just remove things that are or molecules that are what's called lipid soluble, so they're more attached to lipids. What is clear is just removing lipids or reducing cholesterol is insufficient, because otherwise statins would work, and that'd be a far easier thing to do. What plasma exchange tends to do is actually remove water-soluble molecules. The big problem is, at the moment, none of the studies have there are lots and lots of things that are removed and lots of things that are increased by plasma exchange and a liposorber. At the moment, what we're seeing is they're both slightly different molecules, but unfortunately the research is not quite at a stage to know the difference. However, it's probably something to do with the type of molecule that it's removed. But I think with the LDL apheresis, it's probably something attached to a lipid that is also charged that is being removed, or it may be something that's being put back in. We don't know yet, or allowed to act because there's a larger proportion of it. So that sounds a bit waffly, but I think at the moment we just don't know, actually. I think that's the honest answer.
Okay, thank you, Ania. I hope that answers that person's question. So scrolling down now to James Boo, he's saying it's great to hear that there's so much research going on at the moment. Thank you. I was diagnosed with MCNS 37 years ago and still relapsing, but generally doing well. First question, is there much research going on for adults who were diagnosed in childhood and still have NS? And question two, any research into how sleep lack of can cause a relapse, which is often his trigger? Does anybody feel happy to take that question? I would ask Martin, but he's not with us.
I mean, I could tell you sort of just, research into adults. So Nurture is adults and pediatrics, so we are interested in adult nephrotic syndrome as well. There's not much research that's really gone into the natural history over a long period of time, and that needs to be done. And there is the opportunity now that we're collecting all these data that we can start to look into that. I very much agree that more needs to be done to understand both the transition from pediatric to adulthood and what your natural history would be if you had it as a child and over a long period, over decades, what happens to your nephrotic syndrome and what might you expect.
I think one thing I might add is that just when we've been looking at those patients who have the complex nephrotic syndrome and whether or not they have this predisposition gene, which is kind of just a normal variant. It's if we're all the same, we'd all be susceptible to all the same diseases, for example. But it seems to be that as pediatricians, we think, nephrotic syndrome, it goes in your teens. But the more I've looked at it and the more I've examined the group, there seems to be another peak or wave between 40 and about 60. So there's what's called a bimodal distribution. And if you do kind of statistics on it, it's not just because it's more frequent in childhood that you get a bigger peak. But some of that cohort of people who actually continue to have nephrotic syndrome throughout their lives. I think one observation from doing transition a lot and seeing patients up to the age of 30 is we're quite trigger happy with rituximab, and I'm not sure how often that's being used outside the centres I know in adult practice. But I think certainly I've managed to educate our physicians at Guy's that it is actually quite a good drug even in adult patients, and it may be something that isn't always considered, but can actually either resensitize you to treatment or alternatively just basically reduce your number of relapses for some time. That might be part of the issue, actually.
Thank you, Moin and Ania. hopefully it's not James, apparently it's Sally. She's using someone else's account. So hopefully, Sally, that's answered both your questions there. I can't see any other. Yes. Oh, no, we've answered that question. Any more questions for anybody?
There was a comment from Sarah about long-term outcomes. I don't know whether Sarah wants to expand on that.
Thanks, Moin. It's one of the things we've been very interested in that we have this long cohort, or Uday has cohort going on over 30 years. So we thought it would be very instructive to see exactly how the children are doing who've now transitioned to being adults. One of the difficulties, of course, is long-term follow-up. So he's busy sort of chasing up all the data at the moment. Thank you.
Thank you very much. Well, I can't see any more questions in the comment box, so I think that concludes today's event. And I just want to say an absolutely huge thank you to all the speakers. You put in lots of effort with your talks, extremely interesting. And I'm sure those who couldn't attend today will look forward to seeing the whole event on our YouTube account. And I look forward to hearing more about all your studies. And maybe in some months ahead, we could have another event like this. So I think it'd be really helpful to everybody. So thank you so much indeed. And if those remaining people on the call would like to say thank you and wave, so unmute yourself and perhaps wave and say thank you very much to all the speakers, I'd be grateful. Thank you. Have a good day.
Thanks, everyone. Nice to see you very
much. Thank you.
Thank you.
Appreciate it.
Thank you very much.
Thank you. And thank you for your help, Miriam.
Thank you
very much.
Thank you.
Bye-bye.
Thank you.
Bye-bye. Bye. Keep safe, everybody. Bye-bye.
We have to say thank you, Wendy, for organising.
Yes.
You're the key person here.
Well, and Miriam. Thank you, Miriam.
And Miriam, sorry, Miriam.
Pulled all the programme together, bless her heart.
Thank you.
Thank you. Oh, Hugh's still up in Australia.
Still up.
You better go and get some sleep because you're surfing tomorrow.
Thank you very much.
Thank you. Bye-bye.
All right. Well done. Congratulations.
Bye-bye.